everyone, my senior registrar colleagues and all the audience. Here we are today with another senior registrar forum organized by Sri Lanka College of Internal Medicine. And this was actually a brainchild of our own president, Dr. Ganaka Senaratne. So we will be talking today about imaging chest X-rays. It's actually the second episode of imaging. We have done the CT scan in our inaugural one. And to begin the forum, may I invite Dr. Ganaka Senaratne to address the audience. Ganaka, over to you.
Hello, good evening to all of you. Thank you, Priyamali. Can you hear me?
Yes.
All right. You are very welcome for this. I think this is the 7th SR forum of the college this year, I believe. So SR forum has been established in order to help our senior trainees to become competent, confident, and compassionate internists one day. We've been in this mission for about 7 months now. X-rays, especially when it comes to chest X-rays, are really important facet of our day-to-day clinical practice. So I believe this session would teach us a lot to be practiced in the bedside. So I must thank Dr. Asanka Perera, our friend who is doing the second session. I must thank him for his generosity and donating his valuable time on us. Thank you very much, Asanka, for all your help. And Priyamali, our Honorable Treasurer, for passionately leading this project. I believe all our SRs and all the participants joined today would immensely benefited by Asanka's experience, knowledge, and wisdom. Over to you, Priyamali. Thank you.
Thank you, Ganaka. It is my pleasure to privilege to introduce our speaker today. He is not new to us. He is the one who has done the inaugural Senior Registrar Forum about imaging in CT scan. He's a good friend of mine and my batchmate, Dr. Asanka Perera, consultant radiologist from Teaching Hospital, Kalutara. And thank you very much, Asanka, for sharing your knowledge with us. So without wasting much time, I would like to hand over the forum to Asanka. Over to you, Asanka.
Thank you, Priyamali, and thank you, Ganaka. Can you all hear me? Hello?
Yes, we can hear you.
Okay. Is the screen visible to you all?
Yeah.
Okay. Okay. So, good evening, everybody. So today's our topic is chest radiograph, and this is actually a very vast topic, but we will try to do our best within the allocated time. Okay. In this presentation, I would talk about this normal interpretation or methodical way of normal interpretation of the chest X-rays. And next, we will discuss about the interpretation of abnormalities. Now, we are not going to discuss individual abnormalities. Instead, we will try to identify or try to understand the sort of different patterns of abnormalities, or in abnormalities in a clustered way. So rather than going into the abnormalities individually, okay? And we will briefly discuss on chest X-rays of critically ill patients. Now, first of all, we will go through these normal projections. Now, the most commonly encountered projection is posterior-anterior view. So that means the beam goes from posterior to anterior. Patient is sort of facing the X-ray cassette, and the beam goes from posterior to anterior. Now, the AP view is used in kids and in ill patients. The lateral chest X-rays, now in most of the time in Sri Lanka, that we use the lateral X-ray for further evaluation of an abnormality we detect in the PA view. But in developed countries, some countries, chest X-ray means always PA and lateral view together. Okay. And it is usually we do the left lateral, but usually the site of interest should be near to the film. For example, if there is an abnormality in the right lung in the PA view, we should do the right lateral. Okay. Now, there are other projection like oblique view, lateral decubitous, apical lordostic view. Now, these sort of most of the views are no longer we do, then we quickly jump into the CTs. But when you work in a place where the CTs are not readily available, some of these views will be useful. For example, these oblique views are important in the to see the ribs, and this apical lordotic view to see the lung apices as well. Okay. So the most important film in the is the old film, that is to compare with the previous films when it is available. Now we will discuss the methodical way of viewing a chest X-ray film initially. Now I have listed out the checklist like thing, and we will be discussing these topics one by one. Okay. So now when you view the chest X-ray, you don't have to do it in the way that I have listed here, but you should not, miss those areas, whatever your way, but it should include these factors. Now now this request form and identification, always we have to check whether this is the patient information and the chest X-ray are equal and the same patient. Okay. Now we'll briefly discuss about these technical factors. Now, how you see the adequacy of inspiration. Now, usually when the patient is having a good inspiration, you should see 10 posterior 10th up to 10th posterior rib above the right hemidiaphragm. If it is anteriorly, it should be at least 6 ribs should be seen above the right hemidiaphragm. Then look for the situs, that is the orientation of the aortic arch, cardiac apex, and the gastric bubble. Now here, in this X-ray, you can see that if you count 1, 2, 3, 4, 5, 6, 7. So 7 anterior ribs above the right hemidiaphragm. If you count posterior ribs like this, so there are 10 ribs above the right hemidiaphragm. That means, so the inspiration is adequate. It's a good inspiratory film. And look for the situs. Now they have marked L here at the your right upper corner. And you can see the aortic arch to the left. Cardiac apex is projected to the left. And the gastric bubble is in the left side. Now this is the normal situs, and it is compatible with the site marking also. Now then we are discussing about this technical factor, centering. Now a lot of problems are there when the X-ray is not properly centered. Now how you see whether the centering is adequate. So I will show you in the next X-ray. Now, if it is not well centered, when it is rotated, actually, the mediastinal borders get distorted, and the lung near to the film become less translucent. That means it becomes more whiter. Okay. Now here, how you see the centering. Now here you can see these transverse processes of the thoracic spine from the T45 level transverse process to the medial end of the clavicle should be equidistant. The same distance from here to here. Okay. Now here's another example. These are the spinous process. This is the medial end of the clavicles. Okay. So these distance should be equal. So in a well-centered film. Okay. Now another thing that we talk about these technical factors, this is a penetration. Okay. Now, I will explain what is under-penetration and over-penetration. In a properly penetrated film, you should see the vertebral bodies and the disc spaces. It should be just visible through the heart shadow. Okay. Now here in X-ray that you can see these vertebral bodies and the disc faces. They are not too visible. They are not badly visible. So it is fair, just visible. So that is a properly penetrated film. Now this is two examples of under-penetrated and over-penetrated film. Now this depends on the how much of energy that the radiographer gives. Now in a normal X-ray, now some of the the rays will go through without hitting anywhere. Now in the lungs, there is nothing much to hit. So most of the rays will go through the lungs. But whereas in the mediastinum, a lot of bones are there, a lot of soft tissues there. Some of the X-rays will attenuate in the, or will hit there in the mediastinum. There should be a balance to see the details. There should be a balance of the rays which are penetrating through and rays which are hitting in the mediastinum. Now in this underpenetrated one, they have not given enough energy. So many rays have been attenuated or hit in the mediastinum, making the area more whiter. Now you can't see the vertebral definition and the lungs are more whiter. Mediastinum get whiter and you don't see the vertebral bodies through. In the over-penetrated view means that you have given more energy. Okay, so there you can see the lungs are like anguru. The lungs are very black. You don't see the lung nodules or the lung details or the vascular anatomy there. And the mediastinum has penetrated. The rays have penetrated too much through the mediastinum, and these bones are too much visible, like in a X-ray thoracic spine. Now, what happens is in a very obese patient with lot of fat, if you don't give enough energy, it will be underpenetrated. If we in a very thin patient without a lot of fat, if you give too much energy, it will be overpenetrated. Okay, so that is what you call penetration. Okay, then we will talk about the trachea. Now we are discussing the methodical way of weaving the technical factors. Now we are coming into the trachea, mediastinum, those sort of things. Okay, so the trachea should be midline in its upper part, and you know the slight deviation to the right when it comes to the lower. And you should look for the narrowing, displacement when any intraluminal lesions. Okay. And the carinal angle where the trachea bifurcates into the right and left bronchus, usual carinal angle should be 60 to 75%. Now, usually it is increased in the left atrial enlargement or due to subcarinal lymph nodes. Now, here you can see the trachea nicely. So, this translucency decreases when it comes inferiorly, and there is slight deviation you can see to the right side. And here this carinal angle is normal. Here in this X-ray, you can see this trachea is deviated to the left side due to a retrosternal goiter. And there is little bit of tracheal narrowing as well. Here you can see the trachea and this carina. Can you see this carinal angle is widened there? So it is more than 90. I said the normal is 60 to 75. Now this is the patient with the left atrial enlargement that you can see a double heart shadow. There is an extra density in this area that I am pointing with the widened carina. Here. Okay, this is due to left atrial enlargement, probably mitral stenosis. Okay. Now, then after the trachea, we will discuss about the heart and the mediastinum. In a normal chest X-ray, all the heart borders and the mediastinum are clearly defined, except where the heart sits on the left hemidiaphragm. Okay. Now, normal cardiothoracic ratio, you all know that should be 50 or less. Now, the transverse cardiac diameter more than 1.5 centimeter in a serial film is significant. Suppose the transverse cardiac diameter is 12 in this X-ray, but sorry, in the previous X-ray, now if it is 14, that's significant. Okay. Now, how you measure the cardiothoracic ratio correctly? Now, we have to take the maximum inner diameter of the chest. Now, this is the lower line. Okay. Now, Now, in practice, the cardiac diameter we take as a one line, but truly speaking, I mean, the correct way is you have to draw a line through the midline, and you have to get the maximum diameter from that place to the right, so left, and that could be that should be added with the maximum diameter to the right. These two measurements should be added together to get the transverse cardiac diameter. Okay, the transverse thoracic diameter should be the maximum from the inner surface of the chest. Okay, that is how you measure the cardiothoracic ratio. Now the cardiac shadow. Now these are the chambers that the cardiac chambers, how the cardiac chambers contribute to the heart shadow. To simplify, now to the left heart body is mainly formed by the left ventricle. Okay, and the right heart body is the green thing is mainly by the right atrium. Okay, so the left heart border by the left ventricle mainly, and the right heart border by the right atrium. Inferiorly, this blue thing, inferiorly in the heart shadow, there is some contribution from the right ventricle, whereas the superiorly, that is mainly by the left atrium. The pink area is the left atrial appendage. Okay, so in the lateral chest X-ray, the majority in the posterior inferiorly by the left ventricle. There is some anteriorly contribution from the right ventricle, blue one, and posterior superiorly, the majority by the left atrium. And here the right atrium, the green thing. Now we will further discuss about the heart borders. Now I said mainly the left heart border is the left ventricle, but there are some contributions from the other structures which are listed here. Now in the next X-ray, I'll show you those structures. Now we will go through this left heart border this way. Now here, this is the left ventricle. Then above the left ventricle, there's a notch-like area that is the left atrial appendage. Now I'm pointing the pointer there. Above that, that is important structure, this area, that is the main pulmonary artery or the pulmonary trunk. Now above that, this line that I'm drawing, that is the aortic arch. So again, aortic arch, pulmonary artery, atrial appendage or the left atrium, and the left ventricle. In this side, the mainly I said the right heart body is by the right atrium. There's a small contribution inferiorly by the inferior vena cava. And here, this is the SVC, and the little bit of a brachiocephalic artery comes. Now here, sometimes you all are mistaken due to a paratracheal widening or a lymphadenopathy. This is the part of the manubrium that you see. Okay, right. The other structures I'm not going to discuss here. Now there are various stripes or the lines we talk in the X-rays, which I am not going to discuss. But learn about this right paratracheal stripe. This one that I am pointing. Usually it should be less than 5 millimeter. But right paratracheal stripe can be widened due to the anterior mediastinal lymphadenopathy and not. Okay. So other these lines you don't have to know much. Okay. Here also it's a big line, paraspinal line, but don't concentrate on those. This paratracheal line you should know. Okay. Now then the hila. Now we discuss about the trachea. Then we came to the heart and the mediastinum. Now we will discuss the hilum. Okay. Now the hila shadows are composed of vessels, mainly by the pulmonary arteries. To a lesser extent, the pulmonary veins contribute, and there can be some small lymph nodes. Okay. Now, in the majority, the left hilum is higher in position, and that is because the left pulmonary artery runs superior to the left main bronchus. That's why the left hilum is higher. Whereas the right pulmonary artery usually has an anterior course to the bronchus. Okay, but you don't have to know that, but that you should know that the left hilum is higher in position. Okay, but very rarely both hilum can be in the same position, or very rarely the right hilum also can be higher. But in majority, the left hilum is higher in position. Okay, the hilum should be equal in density. they should be similar in size, similar in density, and there should be clearly defined concave lateral borders. Okay. Now, the hilar enlargement is usually due to lymphadenopathy and sometimes due to the vascular abnormalities. Now, you can see these hilar, nice, both are similar in size, and this concave hilar lateral borders. Okay. So that should be there. Now, in lymph nodes and all, this concavity is lost. Now, there are two examples that you can see in the left of the screen. There are hilar enlargement with some lobulated outer margins. So these are lymphadenopathy. The second one is more clearer, that you can see that both hilar are enlarged with lobulated convex outer margin. That concavity is lost. And these are the hilar adenopathy. And apart from that, you can see that right paratracheal lymph node in this patient. Okay. Here. Right. Then we'll talk about the diaphragms. Now, we have to look for the outline, shape, and the relative position. Now, usually, again, as I said, in the left hilum is higher. When it comes to the diaphragms, right hemidiaphragm is higher in position. Why is that? That is because the heart depresses the left hemidiaphragm, not that the liver pushes the right hemidiaphragm up. Okay. So the heart sits on the left hemidiaphragm, causing left hemidiaphragm to be lower in position. Okay. Now, but in a small minority, hilar can be in the same level, or sorry, the diaphragm can be in the same level, or the left hemidiaphragm can be higher. Okay. But in majority, left hemidiaphragm should be lower in position. Okay. Now, difference more than 3 centimeters between two hemidiaphragms is significant. Okay. Now, usually the upper body is clearly seen, but in the left hemidiaphragm, when the heart sits on the left hemidiaphragm, that area is obscured. Okay. And one important point that I want to tell is that the hemidiaphragm contour does not mean the lowest part of the lungs. Now, diaphragm is a dome-shaped like thing. Posterior to the hemidiaphragm and anterior and laterally, there is some lungs. Okay. The contour of the diaphragm doesn't mean that lung ends there. So bear in mind that there is some lungs, and especially posterior to the diaphragmatic outline, there is some lungs, lung tissues. Okay. Now, then we will talk about the pleural spaces and the fissures, and costophrenic angle and the cardiophrenic angle. Now, usually this cardiophrenic angle should be very acute, sharply demarcated in this one. So now this is an example where the right costophrenic angle is obliterated. That is usually due to pleural effusion, or sometimes due to pleural thickening, or due to pleural reaction. Okay. So whatever the pleural disease. Okay. Now these are called cardiophrenic angle. Usually that is also very acute and sharply demarcated. That is cardiophrenic angle. Okay. Now cardiophrenic angle can be obliterated. Now this is an example. This is sort of a not very dense. There's an opacity obliterating the cardiophrenic angle. This is a very common normal finding, that is epicardial fat pad. Then you can see the corresponding CT, that is a fat density. Okay. But the other differential diagnosis for the obliteration of this cardiophrenic angle are diaphragmatic hernias. Then pericardial cyst can be there, pericardial cyst or the pericardial tumors. And the other thing is there can be even the lower lobe lung abnormality also can come to this area. Okay. So the diaphragmatic hernia, one of the, especially this Morgan's hernia can be seen in this area. Okay. Diaphragmatic hernia. Now here, this is the epicardial fat pad. Okay. That is about the cardiophrenic angle. Now, about the fissures. Now, usually in the PA films, sometimes we see the horizontal fissure at the level of the 6th rib. In the oblique fissures, we often see in the lateral film. Okay. Now, this is an example of the horizontal fissure, which is horizontal as it says, and you can see a little bit of fluid in the horizontal fissure. Now, these are the normal positions of the fissures in the lateral X-ray. Usually, the horizontal fissure runs anteriorly, whereas oblique fissure goes obliquely. Now, this is the area, the lower lobe, and this is the superior segment of the lower lobe where the TB and those pathologies are there. Now, this is an anatomical variant. This is called esophagus fissure. And here the esophagus vein runs. Okay. So this is the corresponding CT scan of the esophagus fissure. Now we'll talk about the lungs. Now you don't have to go through all these things that I have written. Now to evaluate the lung, usually we divide the lung into upper, middle and lower zones. That doesn't mean upper, middle and lower lobes. Okay. So that is the zone. So we have to compare the upper zone of the left with the upper zone of the right. So compare with the contralateral zone of the corresponding zone. At the same time, we have to compare the upper zone with the middle zone of the same lung. Okay. So, check the entire lung with the zonal anatomy. Okay. This is a normal X-ray. Now we have to check this upper zone with the upper zone of this area, like that. Likewise. Okay. Now, next, now we have seen the lungs. Then, in an apparently normal like X-ray, there are some areas called hidden areas that we have to go through. Okay. Now, especially when an X-ray is given in the exam and all for us, now apparently normal X-ray, we have to go through these hidden areas. Okay. APCs, hyla, retrocardiac area, and the subdiaphragmatic regions. Okay. Now we will discuss some example about these hidden areas. Okay. Now you can see an extra density in the subdiaphragmatic region in the right, and corresponding X-ray the CT shows speculated lung mass. Right? Now I said previously that there is some lung below this diaphragmatic contour. This is one example. Now here it is a lung mass, and here it is not seen in this area, but it is under the diaphragm. That is actually the posterior lung which runs inferior to the diaphragmatic contour. See this extra density here? It's a bronchial carcinoma. Now here you can see, if you look carefully, an additional extra density in the retrocardiac area. And if you look carefully, you can see the air bronchogram also. So that is a segmental consolidation in the retrocardiac lung. And here you can see another opacity in the retrocardiac area with the air fluid level. Can you all see that? So this is a hiatus hernia. Now here then apical pancreas tumor. If we look now, other areas of the lungs are very much clear. Now here you can see in the right apex pancreas tumor. Okay. Now the hidden area, under the hidden areas, we'll talk about the below the diaphragm. Look for the, now I said that lower lung extend below the diaphragm. Now look for the gastric bubble, any abnormal gas shadows, pneumoperitoneum, calcification, those sort of things. I will show you some examples. Now, this is the now how to differentiate this gastric air bubble from the pneumoperitoneum. We'll discuss here itself. Okay. Now, especially when it is seen only in one side, it is very, especially in the left side, it is difficult you to differentiate whether this is a gastric bubble or the pneumoperitoneum. Now, usually in the gastric bubble, this soft tissues underneath the diaphragm is thicker because it is the diaphragm as well as the gastric wall. It is usually thicker. And if you look carefully, you have this irregular outline that is due to the gastric rugae. And you will see the air fluid level. Whereas in pneumoperitoneum, the hemidiaphragm is sort of a crescent, very thin. Okay. Here it is thicker, more than 3 millimeter like. You will see the gastric rugae and the air fluid level. And here in pneumoperitoneum, it only the diaphragm is there, not this thickness. The gastric wall doesn't contribute to the thickness, so therefore it's very thinner. So these are the we are talking about the subdiaphragmatic abnormalities. Okay. Now this is called Chilaiditi syndrome. That is that interposition of the large vowel or the hepatic flexure in between the liver and the diaphragm. Usually there's no bowel in between the diaphragm and the liver, but here the hepatic flexure or the colon comes to lie in between those two. So this is not free air. These hosta, can you see? These are the hosta of the large bowel. That confirms it is not the free air. That is the that is the colon, not the free air, because of this hostration and the bowel appearance of the large bowel. Now this we'll talk about the soft tissues of the chest X-ray. Okay. Now look for these things which we will discuss in the next few slides. Now here in apparently normal X-ray that you can see multiple lung nodules, like you think this is metastasis. But if you look carefully, that you can see those nodules are not only within the lung area, but those are also seen in the subcutaneous soft tissues as well. So this is a patient with neurofibromatosis. Okay, now these are not lung nodules. Now in a chest X-ray, from anterior skin to posterior skin, everything is superimposed. Anything from the skin to the posterior skin can be seen projected over the lungs. Okay, now here these are in the skin, not in the lungs. Okay. Now these are the nipple shadows. Now sometimes both nipples are not seen. Only one is seen. Then you think it is a solitary nodule. So what you should do is, now if you have a doubt, you can ask the radiographer to do a repeat X-ray with the nipple marker. Then what they do is, now they put a tiny metal thing over the nipple and you put a plaster and you take the X-ray. So then it will confirm whether it's a nipple shadow or a solitary lung nodule. Okay. But because sometimes both are not seen. Okay. Now, if both are seen in the corresponding area to the nipple, you can safely disregard. But if there is a doubtful thing, you can repeat with the nipple marker. Then, especially in children and all, or very obese patients, that you will see these skin folds projected over the lung. Then you will be mistaken, thinking that is a pneumothorax. So the clues are, now in a pneumothorax, now in the skin fold, now here if you can see, if you see carefully, that you can see the lung markings are extending beyond this fold. Okay, here lung markings are there. Okay. Other thing is now in a pneumothorax, there are no lung markings here. That area will be more blacker compared to the lung. Okay, and sometimes the skin fold, you will see that it is extending beyond. I mean beyond the lung to the subcutaneous soft tissues. Okay, so this is common thing in children, but not in normal adult people. But when they are very obese, you will see these skin folds. Okay. Now these are called companion shadows. That is not something important. It's something to disregard. Underneath the ribs, superior to the clavicles. Okay. Now then the bones. Now it is very important to look the bony abnormalities in a chest X-ray. Now these are some of the example. Now in this X-ray, you can see there's a sclerotic deposit in the anterior rib. It's a metastatic deposit. And this X-ray that you can see a large destructive metastatic deposit in the proximal humerus. In the X-ray lower down, can you see some of these old refractures here? And if you look carefully, that there is a lytic lesion in the scapula. Can you see? This is a metastatic deposit in the scapula here. Okay. So look now, like prostatic metastases, multiple myeloma, a lot of bony changes can be seen in this thing. Now, sorry, we will now discuss about the lateral chest X-ray. Now, here in the lateral chest X-ray, unfortunate thing is 2 lungs are superimposed, unlike in the PAV. Now, we discuss about 2 clear spaces. One is retrosternal clear spaces and the retrocardiac clear space. Okay. And these things I will show you in the X-ray. Now, here you can see this is the sternum and this is the retrosternal clear space. And this is the retrocardiac clear space. Okay. And you will see, then I said something about, actually I didn't say, I mentioned that something about the vertebral translucency. Now, when it goes from top to bottom, vertebrae should be more visible in a lateral X-ray. That means in this area, in the superior mediastinum, X-ray beam goes through a lot of structures. That is a compacted area in the mediastinum. So therefore, the vertebrae are not very clear. But when it goes inferiorly, this area mainly going through the lungs. So therefore, the vertebrae are more visible. So this vertebral translucency should be increased when it comes from top to bottom. But suppose if this area is more whiter, that means lower zone, some abnormality is happening. Okay. So look for this vertebral translucency along this line. Then in a lateral X-ray, these hemidiaphragm, both hemidiaphragms and the posterior costophonic angles can be nicely identified. Now we said that the heart sits on the left hemidiaphragm and it obscured the anterior part of the hemidiaphragm. So by that we know this is the left hemidiaphragm. But throughout, right hemidiaphragm is clearly seen. So that then thereby we can identify it as the right. Understand? So this is the gastric bubble. Okay. Now in the next X-ray, I will discuss further. Now this is the sternum and this is the retrocardiac clear space. This is the retrosternal clear space. Now these are the 2 scapulae that you can see. And this is the trachea. And these are the hilum region. And I'm not going to go into details in the hilum, which is not that necessary. And this is the aortic arch and the descending aorta. Look about this vertebral translucency that you can see here. It is more white, and along the way, it gets more clearer. Okay. Now try to identify these 2 hemidiaphragms separately. Now in this one, you can see it from the anterior to the posterior. It is all the way. It is seen clear. So that is right. Now this one, you can see in anterior part, it obliterates. That is because heart sit on that area. That is the left hemidiaphragm. Can you understand that? Now this is the costophonic angles are clearly seen. Even a small pleural effusion can be well recognized in the lateral X-ray when it is taken properly. Okay. Now, this normal the normal methodical way of weaving the X-ray is over. Now, we will talk some of the radiological signs or the patterns which are helpful in diagnosing the abnormalities. Okay. Now, one important sign is Sellerhood sign. Okay. Now, you don't have to sort of you don't have to know what it is, but you have to understand the concept that I'm going to describe here. But now in this particular slide or the next 2 slides, if you don't understand, don't worry, because we will be using this Sellerhood sign in our slides in the future. Okay, then you will understand. Now, simply speaking, Sellerhood sign is now usually in X-ray that heart, aorta, diaphragmatic borders are well seen. Okay. That is because now these borders are in contact with the lung. So therefore, those borders are well seen. Now, if there's any intracardiac abnormality which touches one of these structures, heart, aorta, or diaphragm, so it is when it is touching, it will obliterate that particular border. And if that an intrathoracic abnormality not touching or not contiguous with that border of the aorta or diaphragm or heart, it will not obliterate the border. Okay. Now you will understand in the next few slides what I am going to tell. Okay. So if there, now here you can see, now here there is some ill-defined opacity and right heart border is not clearly seen. Okay. So then we know it is in the middle lobe. Okay. So it is a middle lobe consolidation and you can confirm in the lateral X-ray. Okay. Now another example. Now here is the pleural effusion. Now here you can see that the right heavy diaphragm is not clearly seen. Then we know that is in the right lower lobe or the right lower zone pathology. Because when it is contiguous or when it is touching that particular hemidiaphragm, so those interspace is not clearly seen here like in left side. Okay. This is another example. Now there's a mass here, but it does not obliterate the right heart border, sorry, left heart border. So that means it is not in the lingual lobe or it is not in the anterior or sort of median. But if you look carefully now, this the diaphragm is obliterated by that mass. So that means it's in the lower zone. Okay. So actually this is a lower lobe bronchial neoplasm. Okay. So don't worry about the Silahood sign if you didn't understand, because in this next X-rays, I will be over and over telling about this sign. Okay. Now another pattern that we are talking about, this miliary pattern. Okay. Now usually those are discrete, widespread, tiny nodules. In miliary TB, usually those are same in size, similar in size, usually 0.5 to 2 millimeter. Now this now carcinomatosis, there are some cancers like thyroid, breast, bronchus. There can be miliary. There are so many others. Miliary carcinomatosis. Okay. Now usually in miliary carcinomatosis, those are slightly bigger and they can join together, coalesce together, and more of, I mean, not as uniformly in size like in miliary TB. But in clinical practice, it is really difficult to differentiate those two. Okay. But the history is important in these conditions. Okay. Now, what do you understand by this alveolar and the interstitial shadows? Now, now the interstitial shadows mean that is, now you know that interstitium surrounding the secondary pulmonary nodules. So mainly those are lymphatic and the interstitial soft tissues. Okay. Now usually the interstitial shadows, usually there can be small nodules, reticular, but the common pattern is the reticular nodular pattern. Okay. Now alveolar means it's like a cotton wool, fluffy, ill-defined, sort of a dense abnormality. That means the alveoli are filled with something. Okay. And if the bronchi are patent, there can be air bronchogum. Now, there are a lot of differential diagnoses for alveolar opacities and the interstitial opacities, which you should, I think, know to a certain extent. Okay. We will discuss some of these things in our next few slides. Okay. Now, this is typical alveolar shadows. See these more fluffy, more dense, more getting together. So this is typical alveolar pulmonary edema, bat wings appearance. Okay. Perihilar, this alveolar shadows. Okay. Now this is an example for the reticule, and you can see this reticulation. There are tiny nodules. So this is more of a reticular. Here you can see all these reticular pattern. Okay. Of the X-ray. Now, these are the some differential diagnosis for the alveolar pattern and the interstitial pattern, which I am not going to go into details. Now, this is another entity, this honeycombing. Now, you can see these thin cystic areas, cystic places, and it is predominantly basal areas. Okay, this is honeycombing, thin wall cyst 5 to 10. Okay, now interstitial, fibrotic interstitial lung disease like UIP gives this sort of appearance. Okay. Now this air bronchogram, Now, how the Diaphragm is produced? That means in alveoli are filled with pus or fluid or whatever, but the bronchi are patent. So that's why this branching Diaphragm. Here you can see several examples. Now, Diaphragm doesn't mean it is always a consolidation. Anything filling the alveoli with the patent bronchi can give Diaphragm. Even pulmonary edema, Diaphragm can be seen in ARDS, in even alveolar cell carcinoma. Okay, so don't think that the Diaphragm is just only a feature in pneumonia. Okay, any consolidation can give Diaphragm. Okay. Now this is ground glass appearance. Actually, this is a neonate. Now that is the fine granular pattern which obscures the normal anatomical detail. Okay, this is ARDS of a neonate. I just put to you to identify the ground glass appearance. Okay. Okay. Now another entity that we are going to discuss about is solitary pulmonary nodule. This is common thing that we encounter. Okay. Now there's significant percentage is malignant, and we have to consider the size, shape, and the outline, and whether there are any associated calcifications, cavitation, and associated features like bone destruction, lymph node, etc. Okay. Now it is very important to look with the old film. Now suppose if we find a old film 1 year old and it is hardly any change in this solitary nodule, then we can disregard thinking it as a benign finding. Okay. Now this American College of Radiologists, there are ACR guidelines on solitary pulmonary nodule, and they say what to do, whether to biopsy, whether to follow up. Everything is in this ACR guidelines, and usually we follow the ACR guidelines when it comes to a solitary pulmonary nodule. Okay, so if any person is interested of knowing that, they can follow this ACR guide. They can read the ACR guideline. Now here an example. Now you can see in the X-ray there's a spiculated, dense, irregular mass or a solitary nodule, and this is the corresponding CT, spiculated lung malignancy. You can see here. Now here this is a benign hematoma that you can see solitary nodule, and popcorn-like calcifications are there. And usually the hematomas are common in right lower lobe. This is CT of a separate patient that you can see the popcorn calcification, and there are some fat densities and the soft tissue densities. Now this is confidently we can diagnose in the CT and probably in the X-ray, and you don't need further investigation or biopsy. So this is a benign condition. We can leave it alone there. Okay. Now this is a pulmonary AVM. You can see an opacity here with some sort of tortuous vascular-like structure. Now, if you suspect a pulmonary AVM, you have to do a CT angiogram to confirm the pulmonary AVM. Okay. Now we'll talk about the multiple lung nodules. Okay. Now, in multiple lung nodules in an adult patient, unless proven otherwise, it is metastasis. Okay. So first, always think of a metastasis. Now here you can see a right central bronchial neoplasm with multiple lung metastasis. The primary also in the same field. Okay. So this is a primary. Now this is the vaginous granulomatosis patient. Now here multiple lung nodules with them some cavitation. In the serial film, they are migrating. This is just now the multiple. There are so many differential diagnoses for the multiple lung nodules, which I'm not going to discuss everything. Okay. Now this common thing that we encounter is this granulomas, these calcified extra density, so the pulmonary nodules. Sometimes you will see these old TB changes, which is not very apparent in this X-ray, but there are multiple calcified this thing. And if we do a CT, that if you confirm that's calcium in it, so we can safely stop there without further investigation. The granuloma is not a suspicious feature. Okay, we don't have to do the biopsy. Now, then what are these cavitatory lesions and the cyst? So what is the difference between a cavity and the cyst? Now, usually the cavity is a gas-filled space. Usually the cavity has a thicker wall, more than 3 millimeters. Okay. Cavities which are having thinner wall are called cyst. Okay. Again, the location, outline, fluid level, those things should be important. Now here one example. Now here you can see the upper lobe cavities with some fibrotic areas. This is the TB, all TB changes with multiple cavities. Okay. Now here again you can see a lot of fibrosis and the volume loss, and there's a large cavity here with some intracavitatory body. So this is a fungal ball or a mycetoma of a with all TB changes. Okay. Now, under the cavitatory lesion, we will discuss about the lung abscess also. Actually, this is a pediatric patient, but now here in the lung abscess, you can see this wall is very well demarcated. Inner wall is very smooth, and you can see that they are fluid level. Okay. So sometimes it's very hard for us to differentiate the lung abscess from a cavitatory lung malignancy. Okay, that's why the clinical presentation, inflammatory markers, those are very important in the differentiation. Even in a CT, sometimes it's very difficult to differentiate. Okay. Now this is well defined. Inner wall is very thin and smooth with the air fluid level. This is a lung abscess. There is a little bit of surrounding consolidation here. Now here in an adult patient that you can see a cavitatory lesion, ugly looking, very irregular outline, thick wall, and inner wall is very irregular, and there is some air fluid level. Okay. Now this is cavitatory lung malignancy. Okay. So can you see the difference between the lung abscess and this one? Okay. Now these are the thin cysts or the cyst. You can see those are the pneumatoceles, mainly in the upper zone. This is this pneumatoceles secondary to Staphylococcus infection. Okay. So these are the thin cyst, you can see, pneumatoceles. Okay. Now the next topic is that we will quickly go through the lung collapse. You know this lungs have the different. Now the right lung has 3 lobes, whereas the left lung has 2 lobes. So the anatomy is different in right compared to the left. Okay. But the lower lobes are fairly normal in anatomy. Now you can see this is the collapsed left lower lobe, and here this is the collapsed right lower lobe. Okay. Now this is called sail sign, like a sail in the ship. This is sail sign. Okay. Now can you see that in the medial part of the right heavy diaphragm is obscure here? That is the Silahood sign that I told you before. Huh? In this area, the diaphragm is obscure. That means it is a lower lobe pathology. So that's correct. This is the lower lobe collapse. Okay. Now the lower lobe collapse is symmetrical in both sides. Okay. Now the middle lobe, now left lung doesn't have a middle lobe, whereas the right has. Now here you can see the obscuration of the right hard border. Again, this Silahood sign. Okay. And this is the collapse in the lateral X-ray. This is the collapse middle lobe, collapse consolidated middle lobe. Okay. Now here, this is a subtle opacity at the retrocardiac, the pericardiac region here. That is the right middle lobe collapse. Now the upper lobes, the anatomy is different and it collapses also differently. Now this is the now this fissure goes this way, and this is the collapsed upper lobe, right upper lobe, and with the hyperinflation of the right lower lung. Okay. Now here you can see again the right upper lobe collapse, and due to a right hilar mass. And this is called the golden S sign. You can see it's like a S. Here you can see S. Okay, this is the right hilar mass causing the right upper lobe collapse. So that is called golden S sign. Okay. Now the left upper lobe has a different anatomy and different radiological appearance. Now it is called veil-like opacity. Now when you compare with the right lung, that you can see that is more white, or it is more or less translucent. Okay, it's a veil line. You can see the lung, the veil-like opacity. Okay, and this hilum is prominent here. Okay, now in this X-ray that you can see again the veil-like opacity, and there's a left hilum mass. That is the cause for the collapse in this patient, and the left hemidiaphragm is elevated. That is partly due to the volume loss. Now when the left lobe is collapsed, there's some volume loss and the diaphragm to go up, isn't it? So apart from that, now probably this the phrenic nerve being caught here due to this thing. We don't know why the left hemidiaphragm is this much elevated. Probably the phrenic nerve paralysis, and partly due to the volume loss due to the collapse. Okay, and in children you can see these ribs get sort of close by, crowded ribs. Okay. In adult, usually you don't see much that crowding of the ribs due to collapse, but children you do see. Okay, so that is the left upper lobe collapse. Okay, now we will talk about the highline enlargement. Now I said the highline is mainly composed of lymph nodes, the vessels, but highline enlargement is mainly due to lymph nodes or due to vascular abnormality. Okay, now here you can see this hilum is normal, and you can see the highline angle is good, concave. But here the left hilum is enlarged, and the blunting of the costophrenic angle here causing that means a pleural effusion. Actually, this is a patient with TB. Okay. Now here again another patient with left hilar enlargement due to lymph nodes. Now this is a patient with bilateral hilar enlargement in a sarcoidosis. You can see the lobulated hilar. And again, the lymph nodes along the right paratracheal region or the mediastinal lymphadenum. This is a patient with sarcoidosis. This is another patient with the hilar enlargement in a lymphoma patient. Okay. Right. Now, next topic is unilateral hyperlucent chest. Now, we said that when you look at the lungs, to compare with the contralateral lung. Okay. Now by looking at this X-ray, that you can see the one side is blacker compared to the other side. Okay. Now when you have a difference in the translucency, always try to sort of work out which one is normal, which one is abnormal. Okay. But by looking at that, you will understand this. The right lung looks normal, isn't it? Okay. Now it is a massive pneumothorax. This is the collapsed lung. Sometimes some people get mistaken as a left hilar mass or a hilar mass. Don't get mistaken as a hilar mass for the collapsed lung. Okay, this is a pneumothorax causing unilateral hyperlucence, increased lucency. Okay, another example here. Now here again, if you see carefully, you can see there's a density difference. This is more blacker compared to this one. Okay. So here again, you consider which one is normal. Okay. So we'll say that this is normal, and actually this one is hypertranslucent due to the left mastectomy. So the breast shadow is not there, and probably they may have taken some part of the pectoralis muscle also, making this one to more hypertranslucent. So the important thing is compare with the contralateral lung and try to work out which one is normal. Then after that you try to work out why it is abnormal. Okay. Now the next entity, like we said, the hypertranslucent lung. Now here we will talk about one hemithorax is white, the unilateral opaque hemithorax. Okay. Now there are some poses for that. We will go through the X-rays and then you will understand. Now here you can see this is opaque. One lung is fully white. Okay. And what happened to this mediastinum? It looks like it's shifted to this side. Okay. Now this is a massive pleural effusion. Okay. And massive consolidation also can cause like this. Sometimes if you're lucky enough, you will see the bronchogram. And sometimes, now in the consolidation, mediastinum is not as shifted like this. Even a massive pleural effusion, mediastinum can be central. Okay. Now this X-ray is in a supine film, the pleural effusion. So okay. Now here, now again, left lung is white, unilateral opaque lung. Now here, what happened to the mediastinum? Where's the heart? Heart has, or the mediastinum has shifted to the ipsilateral side. Okay, so that is collapse. Now, in a unilateral opaque hemithorax, always try to work out where are the mediastinum, where are the heart. Okay, now here the previous one, if we go back, now here it's shifted to that side. So it can't be collapsed. Either it is effusion or a massive consolidation or massive pleural effusion. Sometimes a very large mass also can appear as a opaque hemithorax. Okay. Okay, so here in the collapse, you can see the heart and the mediastinum shifted to the ipsilateral side. Okay, here it is a massive collapse. Okay, and if you look carefully, these ribs are sort of coming close together, crowding of the ribs. There is a volume loss. So other supporting features are there. Okay. Now here again, this lung is opaque, opaque hemithorax. Now here this bronchus is no longer seen here. Okay. Bronchus is no longer here. Actually, this is a patient with pneumonectomy. What happens after pneumonectomy? That the cavity is filled with the fluid. That's why it becomes whiter. So initially there's an empty space, then progressively the fluid is filled. Okay. Now this is in this one, the X-ray, that you can see some surgical clips, and the bronchus is not there because they have cut the bronchus there, and there are surgical clips. And here you can see there's no rib. Here in this area, there's no rib. So that means usually to take that lung out, they take 1 or 2 ribs out also in pneumonectomy. Okay. And here that hemithorax is small. So there's volume loss. Okay. And the other lung is hyperinflated as a compensation. Okay. So this is a pneumonectomy. So in summary, in unilateral opaque hemithorax, look for where the mediastinum and look for these evidence of other things. Okay. Now, in children, unilateral opaque hemithorax can be due to pulmonary agencies, which I am not going to show you here. Okay. Right. Now next, our topic is elevated hemidiaphragm. Now, these are some of the things that you day-to-day, what you see. Okay. That's why I try to tell you all as a cluster. Okay. Now, here you can see this elevated right hemidiaphragm. Actually, this is now subpulmonic pleural effusion. Usual pleural effusion is like this, but here you can see this is like that. This is subpulmonic pleural effusion. Now here you can see that elevated hemidiaphragm due to subdiaphragmatic collection with air fluid level underneath the hemidiaphragm. Okay, subpulmonic collection. Right? Now here this is diaphragmatic eventration. You can see that the diaphragm has gone up. These are the large bowel. As I said before, you can see this rostra of the large bowel. So that confirms that is large bowel. Now this in eventration, the diaphragmatic outline is intact. Okay, it's thin out, but it is intact. So this is diaphragmatic eventration. Now this is a common thing that sometimes we get the X-rays for reporting, this diaphragmatic hump. That is sort of the part of the diaphragm which is sort of congenitally thinner, congenitally somewhat defective. So that's why that hump is developed. Okay. So it's an innocent finding, especially when you see same thing in an old film, you can safely disregard that finding. Okay. Now our next topic is the mediastinal structures, mediastinal masses. Now you all know that the mediastinum is divided into anterior mediastinum, the superior mediastinum and the inferior mediastinum. And the inferior mediastinum is divided into 3, anterior, middle, and posterior. Now, you don't concentrate on this slide too much. Now, we should know the normal structures of the anterior, middle, and posterior mediastinum in order to see the pathology. Okay. And here, these now sometimes some structures share not only one part of the mediastinum, both. For example, now ascending aorta is in the anterior mediastinum, coming into the middle mediastinum, like that. So various books or various charts say differently these structures in the middle or the posterior. Don't get upset about that. Okay. Now, anterior mediastinum, usually anterior mediastinal masses, the 4 DDs we call 4 Ts, that is retrosternal thyroid, thymoma, terrible lymphoma, and the teratoma. Okay. Teratoma, thymoma, terrible lymphoma, and the retrosternal thyroid. Now, this is mediastinal mass, now lobulated mass. Now, now again, I'm going to talk about this Silahood sign. Now, here you can see now this is the descending aorta. Descending aorta is in the posterior mediastinum. Okay. Now, here you can see the descending aortic outline clearly throughout. That means this is not in the posterior mediastinum. Okay, because the Silahood is not obscured in the descending aorta. And that you can see this hilum through the mass. Hilum is in the middle mediastinum. That means the lesion is not in the middle mediastinum. Okay, so that's how we call it is anterior mediastinal mass. It doesn't obscure the descending aortic border. It doesn't obscure the hilum. Okay. Now here it is in the anterior mediastinum in the corresponding CT. So it's a, you can see the fat densities of tissue densities. It is a teratoma. Okay. Now here another example. Now here again descending aorta is not obscure. Hilum is seen through. So it is anterior mediastinal mass. So in the lateral X-ray that you can see, it obliterates the retrosternal clear space. I said that this area should be clear. Retrosternal clear space being obliterated. That means now, and in the lateral X-ray, it confirms it's a anteriorly situated mass. Okay. Now this is a middle. This one example of the middle mediastinal mass. This is a bronchogenic cyst. It's a benign thing, but sometimes it can be infected, and usually the thoracic surgeons operate on that. Okay. Now here the posterior mediastinal example. Again, now see this right hard body is not obliterated. That means it is not in the middle or anterior mediastinum, because right hard body, usually the lingular lobe pathologies. Lingular lobe is a part of the left upper lobe. Okay, lingular lobe pathologies obscure the left hard body here, but here the left hard body is not obscured. Now see the hemidiaphragm. Hemidiaphragm is seen clearly. It is not obliterated. That means it is not in the lower lobe. But where's the descending aorta? Let's see. The aortic arch is there. After that, descending aorta, aortic line is not there on the Silahood side. Okay. So that means this is a posterior mediastinal mass. Usually, posterior mediastinal masses are the neurogenic in origin, and they are well defined. So those are neurogenic tumors. This is zoonoma. Okay. So that's how now in every mass we can't differentiate whether this is anterior, middle, or posterior. Sometimes we can, because some masses extend not only in the anterior, sometimes it comes to the middle and posterior as well. Okay. So when these signs are seen, we know, we can say that is where it is, and it will confirm by the CT or the lateral film. And you can see the hilum through here. That means it is not in the middle. Here the hilum is seen through. That hilum is not obscured. So that means it is in the posterior mediastinum. We can confidently say in this X-ray. Okay. Now the pleural disease we will briefly discuss. Now here is a pneumothorax. Okay. This is the, okay. Now look carefully. This is a smaller one. Look carefully whether the lung marking extend beyond this line. Okay. That is the important thing. And don't get mistaken. Sometimes for the thinking it's a hilar mass for the collapsed lung. Okay. Now here, this is not a this is the collapsed lung, not a hilar mass. Now this is tension pneumothorax. Now how you understand it as tension? There is mediastinal shift, and this diaphragm is low and flat. Okay, so this is the tension pneumothorax. Okay, mediastinal shift, lung is fully collapsed, and the diaphragm is low in position. Okay. This is another common thing that you come across. This is encysted fluid in in the fissural fluid. Okay. Now usually it is very well demarcated and nice, and in a lateral X-ray it will confirm. Now how you treat? If you give Lasix and if you repeat the X-ray, this will disappear. The lung mass will disappear. Okay. So, and it is the anatomical position is correct for a encysted diffusion along the fissure. Okay. Now, these are two examples. Now you can see blunting of the cosphenic angle where there is some pleural effusion in the right side, and there is an encysted component along the lateral chest wall, And there is some fissural fluid also. Okay. In this X-ray, you can see this obliterated claustrophrenic angle on the left side. There's a small pleural effusion. Okay. This pleural calcification, those are very irregular, more dense, ugly looking things. There are so many causes for the pleural calcification. These are the pleural calcification. And here you can see the pleura along the diaphragmatic surface also calcified. These are the pleural calcification. This is a patient with asbestosis, which nowadays we don't see much. Okay. And this is pleural calcification due to old TB, that you can see this volume loss of this thing with lot of fibrosis and the pleural calcification. Okay. Then now again, another common thing that we see is this non-specific apical pleural thickening. It is not an uncommon finding in the elderly patients, and we can see it in the CT also. And sometimes due to TB changes also, we will see the apical pleural thickening. But it is sometimes, most of the time, it's an innocent finding in some elderly. Okay. But when you see apical pleural thickening, look carefully for bony destruction and all. We should not miss Pancoast tumor there. Okay. Now the pleural tumors, we will quickly see this is a pleural metastasis. Now, usually the pleural lesions are pleurally based with a broad base towards the pleura. And you can see these are more broad based towards the pleura. But when there's a lung lesion touching the pleura, usually they don't have this broad base appearance. They have sort of acute angle with the surface. Okay. And this is another example of pleural fibroma. You can see this broad base appearance, broad base. And usually pleural fibroma is a benign condition, but sometimes they are very large at the presentation. Okay, this is not that big. It's even bigger. And there's no associated rib destruction, no bad finding. Only it is very big. It's a benign condition. Okay. Now this is mesothelioma. So usually those are very nodular pleural thickening, very thick nodular pleural thickening. And in cases the lung, so you can see that it's engulfing, and because it extends along the mediastinal pleural surface also, and there is volume loss. Compare with this lung, you can see this compared to the left lung, the right lung, there is a volume loss, nodular irregular pleural thickening, which extend along the mediastinal pleural surface also. This is a mesothelioma. Now, this airway disease, now we'll talk a little bit about airway disease. It's a very vast topic that we can't discuss all the things. This bronchiectasis, it can be localized or it can be generalized. Now, in mostly basal, but the TB in cystic bronchiectasis, like, sorry, cystic fibrosis, it is upper zone bronchiectasis. Okay. It can be the ring shadows in cystic bronchiectasis or the tram line, like in other cases. Okay. Now, emphysema, we will discuss in the X-ray snake. Usually, lungs are hyperinflated, diaphragms are low and flat, heart and the mediastinum is very thin out or elongated, and there can be bullae. Okay. Now, we'll see some X-rays. Now, here you can see the tram line like opacities in bronchiectasis. Okay. And here you can see the cystic bronchiectasis with some air fluid level, means there's superinduced infection. Okay. Now, here you can see the cystic bronchiectasis and there's dextrocardia. You can see that the cardiac apex is toward this side, gastric bubble is here, and this is the cartilaginous syndrome. Okay. So, and the patient may be having a typical triad of sinusitis, bronchiectasis at the dextrocytus inversus. Okay. So, this is cystic bronchiectasis with dextrocardia. Now, this emphysema, now I said in the previous slide, here the lungs are very hyperinflated. You can see a lot of ribs are seen. Diaphragms are very low and flat. And you can see the mediastinum is thin out, heart is elongated. Okay. And on top of that, you may be seeing some emphysematous, the chronic lung changes. In this X-ray, not very much seen. And in the lateral X-ray, you can see this retrosternal retrosternal airspace is widened. This is a barrel-shaped chest in the lateral chest radiograph. That is, barrel shape is seen in the lateral chest radiograph. Okay. Now, this is the bullous disease. Now, second to the emphysema, you can see the multiple thin cystic areas devoid of lung markings, multiple bullae. Okay. And this is the compressed lung that you see as the consolidation, but it is not a consolidation. Now, these areas, bullae compresses the lung shadows, causing this compression of the lung shadows, causing some opacity-like area. So these are multiple bullae. Okay. Now, we will talk about, now heart is itself a very large topic that we can't discuss too many things about the heart, but we will talk about the massive cardiomegaly. Now, this is a patient, you can see the large heart, carinae angle is widened, you can see, and lot of lung changes. You can see the lungs are, vessels are prominent, there is fissural fluid, there is some interstitial pulmonary edema, and probably early alveolar pulmonary edema as well. So now in this particular X-ray, we can't say it is dilated cardiomyopathy, but this is massive cardiomegaly. Okay. Now this is a pericardial effusion. Now usually pericardial effusion, heart is globular shape. Okay. Now usually the heart border is well distinct compared to the other X-rays, because now in a normal X-ray, due to the cardiac pulsation, there is some motion artifact in the X-ray. But here the motion artifact is minimum, because after the, beyond the pericardium, there is, beyond the heart, there is fluid. So therefore, that motion artifact is minimum, that it gives sort of a clear definition to the heart border. And the other striking feature is, now here is a massive heart, but see the lung markings. Lung markings are normal. There's no much of the bad vascular marking compared to the previous X-ray. Okay, so relatively clear lungs. Okay, so massive pericardial effusion with the globular heart. Now, in this one again, you can see now, compare this pericardial effusion. Here you can see a lot of perihilar vascular shadows, upper lobe diversion, some interstitial shadows. The lungs are ugly, unlike the previous one. This one, see, lungs are clear. Okay, this is multiple valvular heart disease. Again, carinae angle is widened. So this there is cardiomegaly with some congestive cardiac failure in this X-ray. Okay, now we will talk about the pulmonary arterial hypertension and pulmonary venous hypertension. Okay, now in the pulmonary arterial hypertension, mostly pulmonary due to the intrinsic lung diseases causing increased pulmonary vascular resistance. Okay, so intrinsic lung disease in chronic pulmonary embolism, and when there is a left to right shunt, and sometimes it is secondary to the raised pulmonary venous pressure. Okay. Now, chest X-ray features. Now here you can see. Now here the main pulmonary arteries grossly enlarged, and this is the descending pulmonary artery. You can see the pulmonary vessels are enlarged, and compared to those periphery, the relatively vessels are less prominent. Okay, so the triangular large heart, enlarged main pulmonary artery, and the descending pulmonary artery also enlarged. Again, this is another patient. You can see the large main pulmonary artery and the descending pulmonary artery and the other pulmonary vessels. And here you can see some chronic lung changes, and probably this is secondary to the intrinsic lung disease. Okay, so you can see a lot of lung changes in this one. Now, now the pathophysiology of pulmonary arterial hypertension and pulmonary venous hypertension is different. Okay, now pulmonary venous hypertension and the pulmonary edema, the mechanism is same. So therefore, now when we discuss about the pulmonary venous hypertension, think about the pulmonary edema as well. Okay. Right. Now mainly now no longer that they can keep the lungs or the interstitium dry, the fluid start to leak into the interstitium. Okay. Now, initially what happens is now when the fluid is leaking into the lungs, lung gets stiffer and the compliance is less. So then what happens is when the lung gets stiffer, the venous, the blood supply cut off to the blood supply. When the lung is stiff, the blood supply sort of get reduced. So the due to the hydrostatic pressure and all, these lung changes are more seen in the lower zone. That's why this haziness coming. And when the lung is stiff, when the blood supply is reduced, what happened? There is redistribution of the blood flow to the upper zone. That's why this upper lobe blood diversion is happening. So all those pathophysiology, of course, you know better than me. So that's how the initial haziness, then this upper lobe blood diversion happens. When the venous hypertension further increases, now the fluid is leaking into the interstitium, where the lymphatics are trying to reabsorb those fluid. That is how these curly B lines appearing. So that is the lymphatics in the interstitium surrounding the secondary pulmonary lobules. Okay. So initially the haziness coming, then the redistribution of the blood into the upper lobe, causing upper lobe blood diversion, then the further leaking of the fluid into the interstitium, then you get this curly line where the lymphatics get activated to reabsorb. Then now that also, now the venous pressure increases further. Now all those fluid cannot be reabsorbed. Then you get this interstitial lines, interstitial pulmonary edema. Okay. Then even the next step, what happens in even increase for venous pressure, then this fluid will get accumulated within the alveoli, causing airspace or the airspace pulmonary edema. Okay. Now here you can see the initial pulmonary edema or pulmonary venous hypertension or early congestive cardiac failure. You can see the cardiomegaly, upper lobe blood diversion. Then you can see these curly B line. Then these interstitial pulmonary edema. Now this is another example. You can see the heart is somewhat big. These curly B lines are there. Upper lobe blood diversion is there. There are evidence of sternotomy. That is, the heart is not doing good. That's why he has undergone cardiac surgery. And here you can see the blunting of the cardiophrenic angle. Costophrenic angle. That means a pleural effusion. There are fissural fluid. So this is interstitial pulmonary edema just before the alveolar pulmonary edema. Okay. Now here, this is the typical bat wing, that the next step where the fluid gets into the alveoli and causing the typical bat wings alveolar pulmonary edema. Okay. Here you can see the air bronchogram. Now I said before that air bronchogram doesn't mean pneumonia always. Here you can see the air bronchogram. So this is the pulmonary edema. Okay. Cardiogenic pulmonary edema. Now, what do you understand by the cardiogenic pulmonary edema versus non-cardiogenic pulmonary edema? Okay. Now, if the cause for the pulmonary edema is not due to left ventricular dysfunction, that is non-cardiogenic pulmonary edema, or simply say it is not cardiac cause, it is non-cardiac cause. Okay. Now, now here you can see the cardiogenic pulmonary edema where you can see the heart is big. There are bat wing opacities, upper lobe blood diversion, curly line here. Okay. Now in this one, non-cardiogenic pulmonary edema, you can see that the heart is not that big. It's normal size heart. That indirectly say that is not cardiogenic. Okay. Now I will discuss cardiogenic versus non-cardiogenic in the next slide. Now usually more the cardiogenic pulmonary edema patchy infiltrate in the bases, whereas non-cardiogenic more homogeneous. And effusion is seen in the cardiogenic, whereas in non-cardiogenic, no effusion. Now, curly B lines are there, cardiomegaly is there, okay, And this upper pulmonary vascular redistribution, which I was trying to describe you all, pulmonary vascular redistribution is a feature of a cardiogenic, whereas there's no redistribution of the pulmonary vasculature in the non-cardiogenic this thing. Right? Now, basically in cardiogenic edema, it is fluid, but in non-cardiogenic pulmonary edema, it could be fluid, it could be proteinaceous material, it could be inflammatory things. Okay. Now, what are now you should know the causes for the non-cardiogenic pulmonary edema. I will say some few due to pulmonary edema due to acute asthma, near drowning, due to toxin, and ARDS is one form of non-cardiogenic edema. Okay, I'll talk a little bit about ARDS in the next one. So this is ARDS, the tip features are same like non-cardiogenic pulmonary edema. ARDS is one form of non-cardiogenic pulmonary edema. Okay. Now I said this one before, non-cardiogenic pulmonary edema, underlying cause is not due to LV dysfunction. Now in ARDS, the difference is it's a form of acute lung injury, and there is alveolar damage. So then leaking of fluid into the alveoli. Okay. Now cardiogenic pulmonary edema, if you treat with the Lasix, and if you give some cardiac support, usually it clears off. Now, in the ARDS, there's alveolar damage. It's acute lung injury. So, usually these opacities persist for days to weeks. Okay. And it is now, then there are so many causes for the ARDS, which you should know. Now, the pattern of non-cardiogenic pulmonary edema and the ARDS are same. Okay. Because ARDS is one form of non-cardiogenic pulmonary edema. Okay. Now last few slides. I think I'm running out of time. We'll talk about some of these ICU patients. Now here the central line. Now the central line usually should be in the SVC. Okay. Now in this example, that you can see the central line going all the way along the esophagus system. Okay. Right. Now here, if it is somewhere here, that means it is in the right atrium. Okay. So it should be in the region of the SVC. Okay. Now this ET tube is nicely positioned 2 to 3 centimeters above the carina. Okay. Now here another example. Now this is the migration or it's gone too deep. This is a central line. Now you can see it is in the right atrium. Not only in the right atrium, it has gone to the right ventricle and then into the probably into the pulmonary artery as well. So it has sort of migrated. Okay. This is the PICC line. This is peripherally inserted central line. Usually is for the oncotherapy. This is used in foreign countries. Usually it is inserted by the radiologist initially through the ultrasound guided and the inner side of the arm. Then we advance it through the fluoroscopic guidance to this place. Okay, this is a PICC line. Okay. Now this is the ET tube. Again, it is in good position, 2 to 3 centimeters above the carina. So when you see these patients, always look the tube position and the continuity of the tube, whether the tube is broken. Okay. And usually the ICU, when you see the patient in the ICU, these patients usually they have the serial film. Always compare with the previous film. Now here you can see the ET tube is in the right bronchus, causing, here you can see the hemidiaphragm is obscured and causing collapse of the segmental collapse of the left lower lobe. Okay. And this is the ET, the NG tube that you can see it's coming. Here it is obscured, but again I can see here. Now this is the central line you can see. This is the central line. That is too deep in the right atrium. And what is this one? This is pulmonary arterial catheter. Swan-Ganz catheter. So it is fairly satisfactory in position. Usually it should be the right pulmonary artery. Okay. But here this ET tube is very bad. Okay. Sometimes, now if you leave this tube like that, the entire lobe will be collapsed. Okay. Now here then another one that you can see that NG tube has gone into the right bronchus. If you feed through this one, you will get the chemical pneumonitis and patient will die. Okay. So always when you put a tube, whatever the tube, always you have to check the position with fluoroscopy or with a follow-up chest X-ray. Okay. So that is the important thing. Now this is the ET tube, intercostal tube. Always look for these holes, whether those are inside, and always compare with the previous with this. Here you can see some subcutaneous emphysema has happened. Okay. Continuity, where those holes are and the position. Okay. Sometimes it comes and directed and hitting the mediastinum. Okay. Now this is the pulmonary arterial catheter, Swan-Ganz catheter. You all will see these things when you all go abroad. I think even in Sri Lanka you may be seeing. I don't know. I don't see much often nowadays. Okay. Now this is nicely positioned. It's coming through the internal jugular access, but it's in the nicely positioned in the right pulmonary artery. But here you can see that balloon being inflated. Usually you don't leave the balloon inflated. You only inflate the balloon when you measure the pulmonary arterial pressure. Okay, so this is not very good. Okay, now here you can see again the pulmonary arterial catheter. Position is good. It is in the right pulmonary artery, but it's looped around in the right atrium. That is not good because it can cause arrhythmias. Now see in this patient, you can show various tube. The ET tube is here. It can come here, but it is all right. NG tube is going like that. Okay. Other oxygen tubes, all those things are there. Okay. So always look in the when you look at in the ICU patient or in the critically ill patient, always look always look about. Always pay your attention about these tubes, continuity and the previous position, and whether the position is satisfactory. And whenever you put a central line, whenever you put these things, always you have to get X-ray, especially in the central lines, especially with the subclavian access, there can be risk of pneumothorax, to not only to see the position of the tube and also to see whether there's a pneumothorax, you have to do a X-ray. Okay. So as a summary, what I have to tell is now always compare with the old film. Try interpret methodically. I mean, develop your own way of seeing the X-ray and not to miss anything that we discuss. So interpret methodically and always pay your attention about the hidden areas. And sometimes, I mean, not sometimes, in now this clinicians, especially the VPs, and unfortunately I have to tell that they just say, please report this chest X-ray. Now we don't have superpower to report the X-rays like that. We need clinical history, past medical history, the presentation, examination finding, and the relevant blood investigation to interpret the chest X-ray. Don't say that, please report this chest X-ray. You write, this patient being treated for LRT, lower respiratory tract infection. Please report. Okay, we can't report like that. Okay, always help us with good clinical history, past medical history, examination findings, and the blood investigation. And especially in the chronic lung disease, we need to know the exposure history, those sort of things also. And now don't hesitate to repeat a chest X-ray, because sometimes it is not properly centered. It is not, the patient has not taken good breath. So therefore, now repeating the X-ray will sort out a lot of doubts in our initial X-ray. Okay, don't jump into the CTs. Just get the radiologist's opinion and don't hesitate to repeat the X-ray prior to CT. Okay, so that is what I have to tell you all.
Asanka, there are some questions in this Q&A. You can see that.
Ayo, can you read and tell me?
Yeah, it's one is, can you repeat regarding differentiating different mediastinal masses?
Okay. now that means, do you want to know the, I mean, where's that one? That means, I try to get that. I mean,
I think rather going through all, if you just outline what you have already taught, would be fine.
Okay. I don't clearly understand. I mean,
but the person is in different mediastinal masses.
No, I was trying to tell how to say that is anterior.
Yeah.
Those sort of things. Is that what they want, or?
Maybe they're asking about differentiate mediastinal masses.
Okay. Now in this one, now I said, now these are, for that we need to know the the structures in the mediastinum. Okay. Now in the anterior mediastinum, middle and posterior mediastinum, what are the structures differently? Okay. Now I think leisurely they can go through this list and get an idea what are the structures and what are the pathologies. Okay. Now I said that now by the chest X-ray we can't confidently say in all the time whether this is anterior, middle or posterior mediastinum. Okay. Now some of the features that I said, now for example this one I said, now it is here you can see that the posterior mediastinum not affected as it is not obscuring the descending aorta, and the hilum is seen through, that means it is not in the middle, and the aortic body is not obliterated, so that is not in the posterior. That's therefore we say this is in the anterior mediastinum. So likewise, I mean some of the X-rays that we can say where it is, but in a lateral X-ray that will be confirmed. Okay. Now, anterior mediastinal masses, the commonest thing is the lymphoma, then the teratoma, thymic masses, and the retrosternal thyroid. Okay. Now, in the middle mediastinum, usually what you have is the bronchi, part of the esophagus, and the hilar. So, these hilar masses, bronchogenic cyst, duplication cyst, those are in the middle mediastinum. Okay. Now, what are the things in the posterior mediastinum? So usually the aorta is there, vertebrae are there, nerves are there, and the esophagus. Okay. So now you think what are the structures in that mediastinum? Then you know the pathology. Okay. Now in the posterior mediastinum, we'll go to the posterior mediastinum. Okay. So now, mainly the posterior mediastinal masses are the neuromas, zoonomas, those sort of neurogenic tumors, esophageal